Hello, welcome to Radiography Focus. Today we're going to be going over dorsal palmar, also known as PA wrist imaging, and also lateral wrist imaging. My name is Chris Smith. I'm a radiographer from the Belfast area, and we'll move on to our learning outcomes. So for today's session, by the end of it, we should be able to state common clinical indications that justify performing wrist imaging, describe the correct patient positioning, centering point and collimation for a DP and lateral wrist radiograph, identify the key anatomical structures demonstrated on a correctly performed wrist radiograph, and also evaluate a DP and lateral wrist radiograph for rotation and overall image quality. So before we go on and image a wrist, we must know some clinical indications that justify this type of imaging. So I have a list here that I'm going to show, but if you want to have a wee think about some before I show the list, we have a hint here for a picture demonstrating a dinner fork deformity, which is usually a visual sign for Colles fractures. And this is posterior displacement of a fracture fragment at the distal end. So I'll show you my list here. So we have fall on an outstretched hand, which is very common to result in dinner fork deformity. We have other trauma, pain and suspected fracture, suspected dislocation, any post-reduction checks, ongoing pain, and maybe suspected osteoarthritis, reduced range of movement around the wrist and query cause, known osteoarthritis or OA and query progression, query Kienbock's disease, which is avascular necrosis of the lunate, pre-surgical planning and post-surgical checks, and any other relevant query. So we'll describe the routine DP or PA wrist patient positioning. So we have a picture there of a left wrist and hand on the image detector. So our patient will sit alongside the x-ray table, erect on a chair with the affected side nearest the table. The affected arm is abducted from the body, and the anterior aspect of the affected wrist is placed on top of the image detector. And it is also flexed at the elbow at around 90 degrees if possible. And then we position the radial and ulnar styloid processes so that they are equidistant from the image detector. And it's very important to note that this is a left wrist being demonstrated here. So if you can imagine that if we're looking at that from a bird's eye view, our posterior aspect is at the top, our dorsal aspect, and then our anterior aspect or our palmar aspect is in contact with the image detector. So in radiography, centering points are vital. So for DP wrist centering point, it is a vertical center ray directed at 90 degrees to the image detector, and the vertical center ray is directed to a point midway between the radial and ulnar styloid processes. So we can see in the diagram to the left here, the centering point is accurate. It's important to note that the radial styloid process sits on the lateral aspect, which is just below the thumb, as we look in that image as well. So our collimation and area that we require for DP wrist or a PA wrist, it will be the distal 1/3 of the radius and ulna, the proximal 2/3 of the metacarpals, and the bilateral soft tissue margins. And it's important not to call these our anterior and posterior soft tissue margins, because in the true anatomical position, if we were to look at the wrist as it's appearing now, we would describe it as medial and lateral, And as we said before, the lateral aspect is on the radial side, and the radial side is here, which is just below the thumb. And then this will be our medial side here. It's important to know key anatomical structures when we're talking about wrist imaging. And I have named 14 here, and we'll point them out. So it's very important to learn all our carpal bones, so you can learn your own mnemonic to kind of remember these. But we've got the scaphoid, the lunate, pisiform, trochanterium, hamatate, and then we've got the hookohamatate, the capitate, trapezoid, and the trapezium. We've got then our radius and our distal radius, then our ulna and our distal ulna. We've got our ulnar styloid process, our radial styloid process, our first carpal metacarpal joint, and our first metacarpal, second metacarpal, third, fourth, and fifth. So it's very important to know all this basic anatomy of the wrist to perform its imaging of it. So our projection then, how do we know it's a true DP or PA wrist? So our radius and ulna should not be rotated, and the metacarpals should appear in the true DP position as well, and not show any obvious rotation. And we should have nice clear joint spaces as well. So we've done our DP or our PA wrist, and this is usually performed alongside lateral wrist imaging. So our patient position for this is very similar to our PA. So our patient sits erect on the chair at the side of the x-ray table with the affected side closest to the table, similar to our PA. Once again, our affected arm is abducted from the body, and the anterior aspect of the affected wrist is placed on top of the image detector, and if possible it is flexed at 90 degrees from the elbow. From this position, the wrist is externally rotated through 90 degrees so that our radial and ulnar stylo processes are superimposed on the image detector. And we can see the position on the image on the left of this slide here. Our centering point, as always, is very important to understand and know. So our centering point is going to be a vertical center ray centered directly over the radial styloid process. And we can see this in the image on the left here of this slide. Our collimation for a lateral wrist then, so it's the more or less the exact same. We want the distal 1/3 of the radius and ulna, the distal 2/3 of the metacarpals, and then we want our anterior and posterior soft tissue margins. And it's very important to not get confused and call these our medial and lateral soft tissue margins, because once again, when we talk about our patients or our images in the true anatomical position, we would describe this as our anterior aspect or our palmar aspect, and this as our posterior aspect or our dorsal aspect. Our key anatomical structures then on a lateral wrist, it's important to note that we have our distal radius here. The distal radius will be bigger at the distal aspect and smaller at the proximal aspect, whereas our ulna will be smaller at the distal aspect and bigger at the proximal aspect. So we've got the ulna just here at the back here. We've got our metacarpal bases all superimposed, our second to fifth. We've got our first carpal metacarpal joint. We've got our first metacarpal phalangeal joint. We've got the proximal aspect of the first proximal phalanx visualized here, and then superimposition of the entirety of the carpal bones here. Okay, so our lateral wrist projection then. So does our lateral wrist look like a true lateral should? And we assess this by judging if the distal aspects of the radius and ulna are completely superimposed upon each other, if our carpal bones are superimposed and our second to fifth metacarpal bases are also superimposed as well, our first metacarpal should be adjusted to avoid superimposition of the second and fifth, and it should be here posterior anterior, so it should. Our other image requirements then for DP and lateral wrist, so like all images, there should be an anatomical marker present, there should be good bony to regular pattern visible, and then we should have no artifacts as well. Okay, so we'll go on and critique our first image. So we're looking at a DP wrist here. So we'll first assess the area on it. So we want the distal 1/3 of the radius ulna and the proximal 2/3 of the metacarpals. We would say that the proximal 2/3 of the metacarpals would not be visualized. We've just got the bases really here. Our distal 1/3 and ulna, distal 1/3 of radius and ulna would be included. And we can say that our medial soft tissue border is not visible. However, our lateral soft tissue border is. When we talk about area, we usually bring in our centering point into this. So our centering point should be midway between the radius and ulna stylo processes. So it's appearing more proximal than it should. So therefore, we need to bring our centering point more distal. It's also not midway between them, so we would say that it's also sitting more laterally, and therefore we need to bring it more medially then. Our centering point is sitting here in the green circle. Our projectional errors then, so the radius and ulna do not appear in the true DP position. The ulna is separated from the radius, and if we look at our bases of metacarpals as well, they do appear to be sitting obliqued, similar to an oblique hand. So we would say that our radius and ulna stylo processes have definitely not been placed so that they're equidistant from the image detector. And then when we describe other areas, we would definitely say that there's been no anatomical marker placed in our image. It's important to note then that this is the proximal aspect of our image, this is the distal aspect of our image, and this will be our lateral aspect and our medial aspect, and that's very useful for understanding the position of the centering point and how to adjust it to be more appropriate. So how do we improve then? So we discussed previously the errors with our centering point, and we can then state that our centering point is going to go more distal, and I've included a cross here to help us identify where this new centering point should be. So the centering point should be brought distal from where it was, so that it's midway between the radius and ulna stylo processes. And we also want to bring it more medial because it was sitting too laterally in the last image. We're going to decrease our collimation so that our distal 1/3 of the radius and ulna are present, and our proximal 2/3 of the metacarpals is present as well. Once again, I've labeled the distal aspect of the image and the proximal aspect of the image. So we're saying our centering point is going more distal to from where it was. Projectional errors then, how are we going to fix that? We're going to ensure our radius and ulna styloid processes are positioned to be equidistant from the image detector. So we've ran over how to critique a DP or a PA wrist image. So these are usually combined with a lateral wrist. So we will critique a lateral wrist as well. So we know what our area should be at this point. So our area should be the distal 1/3 of the radius and ulna and the proximal 2/3 of the metacarpals. So we can clearly state that this is not the distal 1/3 of the radius and ulna. It looks a lot less, and I would say that our proximal 2/3 of the metacarpals have been included. Our centering point then, if we draw it out, the center of this image is definitely sitting more distal than it should. It should be directed over the radial stylo processes, and we can say, or the radial stylo process, and this is the radial stylo process here, the distal radius, and this is our distal ulna. So our centering point definitely needs to come more proximal. Our anterior soft tissue border has not been included either. Our posterior soft tissue border has been, and this is also known as our dorsal aspect, and then our anterior or palmar aspect has not been included. Our projectional errors then, so our distal radius and ulna should be superimposed, and we can clearly see that they are not superimposed. The distal radius is sitting anteriorly or at the palmar aspect, and our distal ulna is at the posterior aspect or the dorsal aspect. So we would need to repeat this to ensure that they are superimposed. If we look at our first metacarpal, it is not being projected away from our second to fifth metacarpal, so we would encourage our patient to bring that away and ensure it's in the true PA position. Once again then, our other areas and other errors, so there's no anatomical marker present on this image, so we can't state clearly if this has been flipped or not. So I've labelled the arrows as well, so our yellow is the distal radius, green is the distal ulna, we've got the trochanterium in the blue arrow here, and then our orange is our superimposed proximal aspects of the metacarpals. Once again, I have labelled the proximal aspect of this image on our distal aspect of the image and the current centering point. So how would we improve this image? So we've kind of went through them on the last image or the last slide when we were discussing it, but we'll ensure that we go over it and fully understand it. So our area, as we know, it should be the distal 1/3 of the radius ulna and the proximal 2/3 of the metacarpals. But we also know that our centering point is off, so our centering point needs to become corrected so that it's over the radial stylo processes or the radial stylo process. And ensure this happens, we're going to bring our centering point proximally, so it's sitting to distal, and we want to bring it proximal. Okay, so when we do this, we probably will therefore be excluding the distal or the proximal 2/3 of metacarpal. So what we're going to do is decrease our collimation. Decreased collimation means that we have more area, and we're going to decrease it to include the distal 1/3 of the radius ulna when we have corrected our centering point, and the proximal 2/3 of the metacarpals. As we know then from our projectional errors in the last slide, we're going to ensure that the radius ulna or stylo processes are superimposed, and to ensure this happens, what we need to do is externally rotate our wrist. As we said, our radius or our distal radius is sitting anteriorly or at the palmar aspect, and the ulna is sitting at the posterior aspect, which is also known as the dorsal aspect. And to get the superimposed upon another by externally rotating the wrist will ensure that this happens. So we would describe this wrist as an under-rotated anterior wrist, and as we said, we're going to externally rotate the patient's wrist to ensure that this becomes superimposed. Okay, so that's our teaching session done for the DP and lateral wrist. Thank you very much for watching, and I hope you've learnt something from this. Thank you.